involved and are continuing to be involved in that effort, including the California Maternal Quality Care Collaborative, California Hospital Association and its Hospital Quality Institute, specialty societies like the American Congress of Obstetricians and Gynecologists, to name just a few. There are many, many others involved. One of these parties that has been involved in this effort is SmartCare California. SmartCare California is a group of purchasers that have come together. It is co-chaired by Covered California, CalPERS, our Public Employee Retirement System, and Department of Healthcare Services, representing Medi-Cal. Together across these three co-chair organizations, they cover 16 million lives, or about 40% of the covered lives in California. SmartCare California has picked C-section as one of three key focal areas that it wants to work together on, and they requested some help in developing patient education materials to unify a message and approach around this topic. They specifically wanted materials that would be simple, that would be suited for wide distribution, that would be in sync with CMQCC's provider toolkits on C-section, and that would include both video and print content for online and offline distribution. Next slide, please. So this project was really begun to meet the needs of SmartCare California, but we hope that we'll have much wider distribution possibilities beyond SmartCare. Our goals on this project were to develop consumer education materials, again, both video and print, about C-section for wide distribution that will educate women about C-section, motivate consumers to take practical and meaningful action to reduce the likelihood of having an unnecessary C-section, and encourage informed shared decision-making between women and their providers. One of the things that I want to point out is that we, and this is back on the last slide, is that we went into this work not knowing which actions would make the most sense. Our research was really intended to help us figure that out, to listen to women and to other stakeholders and understand that a little bit better. We also wanted to be sure, excuse me, that whatever we produced would be encouraging of shared decision making. So while these products were going to be geared to consumers, we especially wanted them to be encouraged to work with their providers. So it really needed to work for both of those audiences. Next slide, please. In terms of the partners that have been involved in this effort, the three organizations are CMQCC, Consumer Reports, and the California Healthcare Foundation. This has truly been a team effort of active and engaged partners trying to figure out together what the best approach would be. Next slide, please. In terms of the audiences that we're trying to reach with these materials, the primary audience is really first-time, low-risk pregnant women in California, and we want to reach women across income, race, ethnicity, and geographic segments. So for that reason, we oversampled Black, Latina, and Medi-Cal women. A very important secondary audience are providers, because again, key to this effort is to encourage a partnership. This has meant that there's been some challenging aspects to developing these materials. If you're just going to develop things only for consumers, not taking into account the provider perspective, you might end up in a different place. So we have really been walking a line here in the development process to create something that works and is acceptable and compelling to both sides of the discussion, both the patients and the providers. Next slide, please. In terms of research to date, we have done a number of things, and again, a key goal here was really listening at this stage. So we conducted 24 individual provider interviews with OBs, family practice docs, labor nurses, and nurse midwives back in the spring. Following from that, we conducted 9 focus groups with about 78 consumers to develop messages and approaches, and we did this again, sampling from a wide variety of vantage points, making sure we had good Medi-Cal and private insurance representation, English and Spanish. We conducted these focus groups in a number of geographic areas, and we also included oversampling of African American and Latinos. Lastly, we conducted about 27 individual interviews with consumers focused heavily on Medi-Cal to test the video prototypes. I should mention here too that we started with the video with the idea that if we got that right, we would then build the print materials off of that. Next slide, please. In addition to the efforts and the research that I just described, we also have vetted earlier versions of this video that you'll see today with some key stakeholders, and they're listed there on the slides. And thank you to many of those who met with me earlier and provided really helpful feedback. I now want to turn things over to my colleague Eric Antebi, Director of Communications at CHCF, to walk you through some of the key insights that we gained from the research and a few more details regarding the work, and then we'll watch the two videos together and take questions. Eric?
Thank you, Stephanie. So a lot of what we are trying to do here is figure out what is the right formula to motivate women. Can you go next slide? Oh, sorry. And one more. And so part of what I'll be walking you through is a number of different motivations. We're trying to figure out, like, what is the right formula with sort of the different ways in which women could be motivated to take action. And so one of the key insights is that self-care is actually a challenge for many of the women that we are trying to reach. They are typically in the role of caregiver in their own families already. And so taking care of themselves is not something that they are used to doing. It's kind of a luxury. And the fact that we're talking about moms to be, means that if we could somehow tap into that caregiving mindset, there may be something there. But one of the other challenges is that they're not yet thinking of their baby as a real person yet in need of caregiving. And so specifically because we're talking about first-time moms. And so those are two challenges we had to figure out how to overcome. And what we kind of took from that was, one, that anything we can do to make the need for self-care a little more urgent, that's going to help sort of move them along in that direction, overcome that basic challenge. And then similarly, anything we can do to make the baby feel a little bit more present, a little more real, not just something happening out in the future, that's going to help activate their caregiving instincts. Next slide. And the good news is that women already see C-sections as something to be afraid of. We did one of the first things we did with women in our focus groups was we did a word association exercise where we just asked them what comes to mind when we say cesarean section or C-section. And the vast majority of responses indicated that the basic way that women think about C-sections is that it is something to be afraid of, and that they wanted to avoid them because of that fear. Now, the good news is that fear, it can be a very strong motivator for anybody, but particularly for the women that we are trying to reach. At the same time, we also know that too much fear can be paralyzing. It can kind of shut you down and make you feel powerless. And so we had to figure out what is the right sort of dosage of fear to bring into the picture. And so to do that, we tested a long list of different facts about C-sections to see which pieces of information would help us get the right balance. And the top statement that we tested in focus groups was, because a C-section is a major surgery, it takes longer to heal, and there is a possibility of more complications compared to vaginal birth. The most common complications include infection, heavy blood loss, and a blood clot in the legs or lungs. And so we what we're trying to do is figure out in the least amount of time, how can we get the right amount of response from the women we're trying to reach. And we found that just with this statement alone, we were getting that kind of right, we were getting the right amount of attention, the right amount of concern from women. And the other thing about this is that this was a statement that was not just motivating, but it was actually believable. There were other statements that we tested that women were more likely to question or to push back on because they didn't necessarily trust that it would be true. And this was one of the statements that they found both believable and it was actually motivating in the right way. Next slide. So another thing that we learned was that women, when they find out that C-sections have increased, they are shocked by it. It's not something that by and large women are already aware of, and when they learn, it's something that they become very concerned about, and that gives us an opportunity. It is going to help. That sort of surprise helps to motivate them to take action. The challenge is that it also prompts women to ask why C-sections have increased or why there is variation among hospitals. And we have found that answering that question, why, is something that is very difficult to do in, say, 60 seconds or less when you're also trying to convey lots of other pieces of information. But one of the things that we're taking away from the research that we've done is that the very next thing we need to do, the next product in the series of education products, really has to hit directly at this question of why C-sections have increased or why some hospitals do more than others. Another aspect of motivation is the idea of empowerment, and we found that there was both a need to empower women to feel like they can take some action that will make a difference in their lives, but also that empowerment messages can be very effective in this situation. So it's important to remember that for a lot of the women we are trying to reach, the healthcare system is very, very intimidating. When you're talking about low-income women in particular, they generally don't feel like they have a lot of agency or power in their own lives to make a difference for themselves or their families. And so part of our job with this outreach is to help build them up, to give them confidence so they feel like they can influence what's happening around them. And the top empowerment statement, we tested a number of different statements. The top empowerment statement that we tested was, your voice matters for you and your baby. And we tested other empowerment messages as well, and we found that they weren't effective with many of the women, in part because it was easy to sort of take the wrong message from it. So if we had a message that said, your body is made strong for labor and for birth, you would think that might be empowering, but it actually raised concerns about mommy shaming and making women who did have to have a C-section for some reason, were they going to be sort of lesser? Was their body not as strong? And so we really needed to find an empowerment message that didn't have any of those drawbacks or any of that baggage. And so the idea that your voice matters for you and your baby was the one that very clearly rose to the top and was really kind of a consensus favorite among the women we've tested this with. So I know that Stephanie mentioned earlier that we went into this process not knowing entirely what we could ask women to do in this campaign. And we had to sort of integrate or address different factors and find something that kind of fit in the sweet spot among sort of different factors. One is, what does the literature say is actually a meaningful step what's going to actually reduce the chances that someone will have a C-section. Two, what are women themselves willing to do? What feels doable to them? And three, what do we think providers want to see and hear? Again, because we're trying to find something that that providers will support. We want these to be materials that they're going to help distribute. We're going to want them to be a positive kind of collaborator or partner with women. And so we really needed to make sure that whatever we were asking women to do was something that we knew providers wanted to see more women doing. And so finding something that fit those three different needs was tricky, but we think we found kind of a good combination. One is that just simply strengthening a woman's mindset to avoid a C-section, that in and of itself helps to reduce their chances of having a C-section, or increases their chances of having a vaginal birth. And so just helping to really sort of get them to commit to themselves, or to prefer for themselves or with others, to sort of state that preference for having a vaginal birth, that's going to help improve their outlook. And so that's kind of an internal behavior change, because we're just trying to shift their mindset, but that is meaningful. Two, we learned that women were really ready. The first thing that they were willing to do was just to get educated, to go online, to get more information about how to avoid a C-section. That was something that felt very, very doable to them. And the third was that women were willing to talk to their doctor and others, their nurse, their family members, to express a preference for avoiding a C-section, and also to seek help, to find out what they can do. And we did test other asks, other behaviors with women in our focus groups in particular, and they just weren't as effective. So, for example, we know that there is literature that shows that women who take prenatal classes are more likely to have a vaginal delivery, but we didn't feel like we could really ask women to go out and take prenatal classes, because they're not really as available as we would want them to be, and we felt like that would kind of put women in this difficult spot of wanting something that then that they weren't going to be able to follow through on. And then the other one that we asked about was, would women be willing to not come to the hospital too early? Would they wait a little bit longer once the contractions begin before heading to the hospital? Because we know that also has a link between whether women end up having a C-section. And women were very, very clear with us pretty much across the board that as soon as they start feeling the first contractions, they are going straight to the hospital. They did not want to wait at all. So we felt like that was a very, very unrealistic ask to make of women. So that's really, hopefully helps you see there were some things we really had to kind of rule in, and some things we had to rule out, and we ended up with these three that we thought in combination hit the sweet spot. So one of the other things we had to figure out is who is actually talking to the women, who is going to be most persuasive with them in these educational materials. And we found pretty quickly in our focus groups that many women are inclined, they've had just bad experiences with doctors in particular. And we also know that there are groups of women who are more likely to distrust doctors. There's concerns about things that they've either heard or seen in the medical system overall, and so it makes it makes doctors kind of a complicated messenger, because you don't know which women out there are going to really trust their doctors and which women are less likely to trust their doctors. And so we knew that we needed to have some kind of professional voice delivering reliable information and facts about C-sections. And we thought, we had a hunch that labor and delivery nurse would be an effective messenger. We know how trusted nurses are in society. They're among the most trusted professionals in our society. And then when we tested that hypothesis in the prototypes of the education materials, that hypothesis has so far proven to be true. And so nurses give us that kind of professional messenger without having the baggage that could necessarily come with a doctor messenger. We also thought that we just know that women, like most people, they tend to like to get information from people like them, from people that they know, from friends or family. And so we thought it might work to have a messenger of a new mom, someone who has recently been through a pregnancy and childbirth, who could then kind of tell other women what she learned. And we then tested that in the prototype and found that hypothesis was also true, and it was also very effective. I just want to make sure we're very clear that ultimately our goal is to create more trust with doctors, and all of this is in the service of actually getting women to talk to their doctor about labor and what they can do to promote a vaginal delivery or a vaginal birth. But the nurse and the new mom are the ones who are probably in the best position to kind of encourage women to reach out to their doctor and have this conversation. So there are a lot of different ways we probably could have gone in terms of the format for an education campaign like this, and we decided to use animation, not for any one reason in particular, but really because of many reasons all kind of coming together and pointing us in this direction. So one of those reasons is that we really wanted something that had a very distinctive look and feel. It wasn't there's a lot of other material out there about childbirth and even about C-sections. And we didn't want to just to be part of the noise. We really wanted to kind of stand out in a new way and have something that was a sort of fresh and memorable look. We also knew that we're trying to do something in like 60 seconds or less. We're trying to communicate some complicated ideas and address a lot of different complicated emotions. And we just felt like animation would give us a little bit more flexibility and kind of a creative canvas to express some complicated ideas, or to talk about to kind of walk women through a process. We also know that California is a very diverse state. We weren't going to be, if we were doing something with say live action video or traditional photography, we'd have to have many different versions of something in order to represent, age and ethnicity in a way that the diversity of women could relate to. With animation, you can be a little more ambiguous, and because it's animation, audiences are more likely to kind of cut you some slack, because they understand that the animation is really sort of generalizing. And they're less likely to, say, judge a character in an animation because it's not exactly like them. Another is that we wanted the ability to create print products in the same visual style. If we could develop that style in an animation, everything else we would do would sort of flow from that. And then finally, we don't have unlimited resources, and animation it would just prove to be more practical and cost effective compared to live video, where you'd have to go out and get lots of different footage and lots of different characters to relate to the many kind of subgroups of women we're trying to relate to. So one last point, as you'll see when we show you the videos, in one of the videos, we do include some specific data about hospital variation, but we've been trying to sort of experiment with different ways of presenting that information, and at this moment we're not really sure which direction we're going to go in, and so we're still testing two approaches. In one, we're showing that hospitals have C-section rates of 1 in 5, or 1 in 3, or 1 in 2. And in the other, the very same percentages are represented in 2 in 10, 3 in 10, or 5 in 10. And I know that the traditional sort of literature on communicating numbers says that you want to have a common denominator as much as possible, that's a more effective way to show comparison between different statistics. And so that's why we're testing that approach with the 2 in 10, 3 in 10, 5 in 10. But we also have found that that if we use the 1 in 5 or 1 in 3 or 1 in 2, women, there's a potential for women to see themselves as the one, right? I don't want to be that 1 in 2. And so in this next round of testing, we're going to try both versions and see which one is more effective. And at the end of the day, we'll sort of go where that evidence leads us. But each one has some merit to it. So in terms of next steps and where we are with this process, we are actually starting tomorrow going to test what we call the rough cut of the videos, and also our first versions of print materials that we've created from these videos in doing some one-on-one interviews with target moms, and then we also simultaneously are having this webinar with all of you so that we can get a broader group of stakeholder groups to provide input. After this, we may make a few tweaks to the materials based on what we learn from you all and also from the testing. And then we're going to do some secret shopper testing, because we want to see what actually happens when women see these videos or the print materials and then go have a conversation with their doctor. We want to find out what that was like and what happened as a result of it. So that's really the goal in the secret shopper testing. At that point, we'll finalize the materials, and then we're really looking at the first quarter of the new year to really get the dissemination process underway. So I think what we want to do right now is actually show you two videos. We actually have 3 videos that we will be testing. 2 of them are almost identical, but there are a couple little places where we're doing some A/B testing. We're not going to, and the data, the 2 different versions of the hospital variation statistics are one of those places. So we're just going to show you 2 videos. One is going to be from the perspective of a labor and delivery nurse, and the other is from a new mom.
Hi, I'm Lucy, and I'm a labor and delivery nurse, which means I help a lot of moms have their babies. Did you know that hospitals do a lot more C-sections now than ever before? In fact, your chances of having a C-section can be much higher at some hospitals than others. Let's say you have a normal, healthy pregnancy. At one hospital, your chances of having a C-section could be 1 in 5. At another, 1 in 3. And at another, it could be as high as 1 in 2. Why the difference? Some hospitals are quicker to perform a C-section than others, even when they could have been avoided. This matters because if a woman has a C-section, there are more chances for complications like infections and heavy blood loss. And it's a major surgery, so it takes longer for the mom to heal. Remember, it's your birth. By taking steps early, you can make a difference for you and your baby. Talk to your doctor, nurse, midwife, and family members. Let them know you only want a C-section if it's absolutely needed. Then ask how you can work together to reduce your chances. Your voice matters. Educate yourself and talk to your team today.
Hi, my name is Nicole, and I'm a new mom. When I was pregnant, I learned that more C-sections are being performed in hospitals than ever before, even if the mom and baby are healthy. This worried me, so I decided to educate myself. I learned many things I could do to avoid having a C-section I didn't medically need. I learned how to talk to my doctor about what I wanted for me and my baby. And I brought a friend to my doctor's appointment in case I was too nervous and needed support. I told my doctor I wanted to avoid a C-section unless it was absolutely necessary. When I got to the hospital, I told my nurse too, and she was really helpful during labor. I know there are many things in life I can't control, but I believe it's better to do what I can to make a difference, especially when it comes to my baby. Remember, your voice matters. Educate yourself and start talking to your team today. If I can do it, so can you.
This is Stephanie again. So those are the two videos that are the outputs of all of the work that you've just heard about from Eric. We'd be happy now to take some questions. You have the ability to submit questions on the panel that you should see on your screens. We'll give a few minutes to let those questions pop in, and then we will read them out and share them and try to answer them. While people are submitting questions, one point I want to make sure is I think there are many of you on the call who are very well familiar with the C-section effort in the state. But for those of you who are not as familiar, I want to make sure that it's very clear that there's no part of this work that is trying to say that C-sections are not necessary in some circumstances. And in fact, the statewide effort is trying to reach the national goal of 23.9 or almost a quarter C-sections, because we know that they definitely serve an important place in the delivery process and can be really life-saving in some circumstances. This project is really about trying to get those women that didn't really need one, who maybe were rushed or had other issues in delivery, and those C-sections could have been avoided. And that's really critical, because with each subsequent C-section, you run the risk of even more and more complications. And once a woman has a C-section, she's 90% likely in the next birth to have a C-section. So really, once you start down that path, it sets you on a trajectory that really can lead to more complications. So I just wanted to make sure that those that maybe aren't as familiar with the effort in the state know that piece. And that's really the message that we were trying to get here. So let's see, we have a few questions coming in, and I will try to, some of them are short, so I want to make sure, I don't know if I can see this. The second, let's see, one question is, can you add doulas and childbirth educators as part of the group of providers to talk to?
Well, again, we have a challenge of trying to convey as much as possible in as short a time as possible. and so what we're really trying to do is to create sort of a formula for how to do this in the simplest and most basic way. But I think once we establish that, we do think that there is a great deal of potential to sort of build on it. So I already gave the example of, for example, of the doing something that addresses the question that women have about why C-sections have increased. That's something that we see as kind of another piece that we would add on to. And I think there certainly is more that theoretically could be done to help women understand the benefits of working with a midwife or a doula. And we certainly want to engage childbirth education centers and others to be kind of part of the dissemination of this. And we're sort of open to figuring out, how to make this work for all of them. But I would say that it would be, if the question were, can we name doulas and other childbirth educators in a video with 60 seconds or less? Probably not. But that doesn't mean that is not a very, very important group that we want to have as part of this work. It's just that we're trying to say as much as possible. And even with midwife, we are actually doing an A/B test to see whether having the midwife mentioned really does help bring more women along and gets them interested in working with midwife, or if it creates confusion, because there are a lot of women out there who don't even know what a midwife is. And again, in 60 seconds or less, we're trying to avoid as much resistance as possible. We want that to be sort of the gateway in. And then once we have them in, then I think there's a lot of other things we could do.
And one thing we should note at the end of the video, there's a website listed there. Right now that website doesn't exist, but it will exist by the time we launch. And on that website, which will be housed at CMQCC, the California Maternal Quality Care Collaborative, there'll be a consumer focused page on as part of their materials. We will include there a lot of information about midwives, about doulas, about labor practices, things like that. Things that we can't get into in any meaningful way in 60 seconds. So again, we're hoping that people look at this video and realize we've got 60 seconds to pique interest and get people to take action, and we can't put everything in, and we don't want to put in things that, like Eric said, can cause confusion if they're not familiar with terms. And we hope that when they go to the website, they will then be exposed to some of these other things. I hope that makes sense. And I'm happy if whoever asked that question wants to contact me separately. I'm happy to talk more about that. We have a question from New Jersey asking, will this campaign be able to be shared beyond California? We would be extremely pleased if other people in other parts of the country wanted to pick any part of this up. All of the materials will be free and available. We actually, and there's nothing California specific about the videos, and that's partly intentionally because we do hope, like the toolkit that the California Healthcare Foundation funded the California Maternal Quality Collaborative to produce for providers, that has had a large uptake beyond California and also internationally. We hope that these educational materials will be a companion to that and that others can use that. So definitely yes to that question. In terms of attribution to this initiative, when we release the information, we'll share the appropriate attribution there. Let's see, we have a statement. I think it would be best to include doulas in videos because they can be a major support system. Again, we totally agree. What we're trying to balance here is if we raise a term that a lot of women aren't familiar with, are we kind of distracting from the main thing that we're trying to get them to do in the video? And again, we hope to have materials on the website that will definitely address some of these other issues that we can't cover in 60 seconds. Is there evidence that including a doula, PA, NP, or midwife in the care teams in reducing C-section? And if so, could we mention them? So we're getting a lot of questions here on the same themes. And again, it's the same answer there. A question here that we're well familiar with. Many moms cannot choose where they deliver. If they research and find their hospital has a higher rate, how will they move forward? We definitely had a lot of discussion and debate about this particular topic, and we certainly realize and are well aware that many women cannot change their hospital. Nonetheless, we do think it's important that they realize that there are C-sections that are being done that are not entirely necessary, and that if they are going to a hospital with a higher rate, that they should know that, and that may prompt them to do things like engage a doula or bring a family member and educate themselves. So I guess our team didn't ultimately feel that not telling women was the right way to go, that it seemed more important for women to be informed about this and then go from there, go from a sort of position of information.
And one other thing I would say is that we aren't actually in this sort of basic part of the campaign. We aren't telling women that they should switch hospitals or anything like that. The ask is really to talk to their doctor, to talk to their family members, to talk to their nurse, and also to get educated and just to have a stronger kind of inner preference for having a vaginal birth. And if they do those three things, we are hopeful that even if they end up at a hospital that has a higher C-section rate, they're going to be putting themselves in the best position possible given their circumstance. And so that's we're hoping that the three sort of behaviors that we're focusing on kind of work anywhere. Obviously, it works best if you're going to a hospital with a lower C-section rate, but they still should help in any situation.
I want to make sure that our colleagues who are part of this team, who have been involved in this work, who are on the line, are unmuted, have unmuted themselves, and are also free to chime in here. Dr. Elliott Main, I see you there. I don't know if you're muted, but feel free to chime in. I don't know who else from the team is on. I'll keep going with the questions here. There's a very interesting question. Again, we gave a lot of thought to unfortunately, the top reason, or might be the second after facility, for unnecessary C-sections is the provider, and the bait and switch used by a lot of them to justify surgery, especially around 36 weeks. So the trust component is definitely an issue. We certainly recognize that, and telling people to go talk to their provider when their provider might be the one who is actually is sort of engaging in doing unnecessary C-sections, that is a sort of circular issue. What we are hoping is that obviously through the provider toolkit, through the hospital collaborative that CMQCC is deeply engaged with, at least now about 100 hospitals in the state, we are hoping that is sort of addressing the provider side, or will address it over time, so that if you are directing women to talk to their providers, they're actually going to have a productive conversation with an educated provider who understands the evidence, who understands the different issues, and they can have a well-informed discussion together. I realize we're not there yet, and that we still have this kind of sort of predicament, if you will, that we're directing women to talk to their providers who might be the very ones who are doing the C-sections that are not needed. But that's sort of where we are right now. We have to begin somewhere, and we hope that that's what all of this work. And again, the consumer piece is one piece of a very large effort in the state that's trying to attack this issue from a number of vantage points.
Yeah, and I would say that even though providers are not the primary audience for this, one of the things that we are hoping for, and it's why we have spent so much time really trying to figure out what providers want to see in terms of the messages going to women, and also what behaviors they think could be most effective in changing. We're hopeful that we're creating a more kind of common understanding and common goal of trying to reduce C-sections and promoting vaginal birth. And so, maybe the doctors are not all where we want them to be today in terms of their ability to have that constructive conversation with new moms. But hopefully, as part of this effort, they'll they'll be more patient, more receptive, more ready to have that conversation because they're seeing the same materials that women are.
Elliot,
This is Elliot.
Go ahead.
Yeah, Elliot Main. And just to build on Eric's comments a bit, I think one of the goals of this is pure and simply to have a larger group of women approach their doctor and say, I really want to do everything I can to avoid a C-section. Giving them the clear message that about what their goals are. That's sort of the story about episiotomy. That is something that has been reduced by about 80–90% in the last decade, largely because women told their doctors they didn't want to have it. And this is a more nuanced, more complicated discussion around C-sections because this is about the baby as well. But I think that ground needs to be staked forward with a statement of patient preference here. And I think if more and more women say that, that will be a powerful message to the physicians.
Thanks, Elliot. And for those who aren't familiar with Dr. Main, it's Dr. Elliot Main, who's the medical director of CMQCC and who has been part of this development team and is an OBGYN himself. Another question, are you trying to choose between these two approaches in the testing that we're continuing to do? And if yes, this particular commenter mentioned that they came down very strongly on the point of view of the mother, and that really resonated. We wanted to develop a couple options because we have we're hoping that we're going to have several different distribution channels for this information, and depending on what type of organization or what type of patients you serve, we wanted to have some options. We'll continue to weigh that. I think the feedback generally that we're getting is that a lot of people really resonate with the mother video. So that's.
Yeah, I mean, I would say, at least when we were testing, in the focus groups, and then when we developed prototypes and began testing them with new moms, what we have generally found is that you get some groups of new moms who really are drawn to the story of Nicole, the new mom, relating her experience. And there are some women out there who want the facts, and they want something that sort of feels a little bit more solid. They don't want just kind of an anecdote. They want some data. They want to feel like they're doing their homework. And so having both approaches available allows us to reach different women depending on, where they, what they're most interested in. But if we were to determine that either approach really didn't work, we're not going to put anything out to the world that hasn't met at least some sort of minimum standard for effectiveness.
Another question is that C-sections can cause complications not only in the mom but also the baby, and was this aspect noted in your research, and was there a consideration to include this in the video? And the answer is yes. We started this process by looking at the evidence and coming up with a list of the many different complications for the mother and the baby that we could test. And in doing that testing, we landed on the few statements that are there because those resonated best. And I don't know, Eric, if you have anything to add there.
Yeah, I mean, the thing that's really interesting is obviously there are lots of reasons to not have a C-section and lots of reasons to have a vaginal birth. But we don't necessarily need to give women all of the reasons in order to get them to take the meaningful steps we want them to take. And again, what we're trying to figure out is what is the right amount? What are the right pieces of information that just get them going in the right direction? And again, in the sort of most we can say in the least amount of time. And some basic, even just saying C-section already kind of starts the process of motivating them, but getting them to focus on some basic concrete things like the fact that it's major surgery and has higher potential for some basic complications to the mom. That we found that was enough. That has been enough to really kind of get the amount of motivation that we're looking for in this kind of initial communication.
Let's see. Another question, will there be similar outreach to OB providers on the value of childbirth education and encourage them to recommend this type of education for pregnant patients? I think, as part of this entire statewide effort, we're trying to encourage providers on a lot of different fronts. This particular educational campaign is not targeted at OB providers in that way, but certainly I think as part of the conversations that are happening in hospitals in the Quality Improvement Collaborative, there are a lot of things that I think a lot of providers are realizing that they could do and encourage that would help the consumer. So this project is not directly addressing that. Let's see. Sorry, I'm just going through these. Okay, another question. The message in both presentations needs to be one of encouraging and engaging in a two-way discussion between moms-to-be and their healthcare providers regarding the risks and benefits of a C-section. Instead, what is unfortunately coming through is an oversimplified message of just say no to C-section.
I'll say, so that's a really great point to raise. We are actually going to be testing whether or not that is what women take away after seeing these videos. We really want to know whether they understand whether C-sections are sometimes necessary, but that it's still something that they can try to take steps to kind of minimize their chances. But we don't know for certain whether or not that's what they're taking away after watching these. So we're going to specifically test that.
Another question: has there been any thought about having a video series? At this point, we have our hands full trying to get these right. I think there is interest to have a follow-on short video that at least begins to address some of the why questions that Eric alluded to earlier in the presentation, because that was such a big response. And I think as anyone who knows about this particular issue, it's a very complicated story why this is happening. It's not just providers. It's a whole constellation. We have payment incentives that are misaligned. We have providers. We have a culture that has come to accept this surgery in a very kind of broad way, and not maybe recognizing some of the complications and the importance of avoiding one if you don't really need one. That's kind of the next thing that we were going to try to turn ourselves to after these videos are completed. In terms of a series beyond that, I think we don't. That's not on the horizon at the moment, but it's an interesting idea.
I mean, I'll give you sort of my 2 cents on it. Is I'd love to get at least the first couple of products out there into the world and kind of see how they do and see what kind of interest there is, and if it takes off, if it really works, then there is no shortage of additional components that we could add to it to go into more sort of depth in specific topics. But I think we'd want to let's work with what we have or what we're already planning first, and then see where we go from there. But the whole idea here was to create some foundational messages, a basic kind of brand and look and feel and style, so that if you wanted to add anything, in the series, you will have already done a lot of the work, and it should be a lot easier to pull off.
Couple last few questions in our last couple minutes here before we wind down. One question is, will this be a public service announcement, or how will this be shared and scaled up? As I mentioned earlier, the materials from this project will be made available for free. Anyone can download the brochures and produce them, and that are the print materials, and the video will also be available. we are hoping that a health plan might embed the video in an e-newsletter to their members, or maybe a physician's office or other provider office might show this in the reel that is running in the patient waiting area. Social media. There are entities like What to Expect and Baby Center and those types of for-profit entities that share educational materials with women that, again, they could be embedded in there. So there's a lot of different dissemination possibilities, and we're hoping to reach as many, starting with the Smart Care group that asked for these materials, and reaching their constituencies, and then hopefully, and we welcome ideas on, if people have ideas, please contact us. I know we're right at 2 o'clock, and so even though there are a few more questions here, I'm going to be respectful of time and sign off. Thank you, everyone, for joining us today. We will make this the recording of this webinar available shortly. So if you want to see it again or pass it on to colleagues, we will send out where that can be found after this webinar concludes. And again, if you have additional comments, we welcome contacting either Eric or myself at California Healthcare Foundation. And thank you again for your time today.